Our next speaker is Dr. JoAnn Manson, and she's a person that needs no introduction. And she's going to talk about vitamin D and the prevention of cancer and cardiovascular disease.
Well, good morning again. So in the previous talk, I really focused on the skeletal outcomes and some of the reasoning that went into the Institute of Medicine dietary reference intakes. What I'd like to focus on in this second talk is the evidence for non-skeletal outcomes in relation to vitamin D, particularly cancer, cardiovascular disease. I do want to tell you about this large-scale national trial, the vitamin D and omega-3 trial, because it's still in a recruitment phase. There are opportunities for scientific collaborations. You may also want to refer patients. That would be great. And I think that you'll be interested in hearing about it. I also want to point out that in your syllabus, after there are the slides for the first and second talk, but after those slides, for the first talk, there was a brief overview of the IOM guidelines and sort of what clinicians need to know, information that may be helpful, just kind of summarizing the process that was published in the Journal of Clinical Endo and Metabolism. And then after the slides for the second talk, there's a perspective piece that we just had in New England Journal about the evidence for vitamin D and prevention of cancer, really goes through some of these issues. So again, I don't really have any disclosure, any financial conflicts. So the goals of this talk are to describe biological mechanisms and the current state of the evidence that vitamin D is related to a reduced risk of cancer, cardiovascular disease. I think it's really with some of these non-skeletal outcomes that the popular press and even some of the medical research has really gone wild a little with high-dose vitamin D as the miracle cure, the panacea. And so I think we need to look carefully at this evidence and decide whether you think it's ready for prime time in terms of the use of higher dose vitamin D beyond the RDAs for the purpose of preventing cancer, cardiovascular disease, some of these non-skeletal outcomes. I want to review the IOM's recommendations for vitamin D and the role of the non-skeletal outcomes in the decision-making process, explain the rationale for large-scale randomized trial to evaluate vitamin D in prevention of cancer and CVD, and I will present to you the design and some of the dosage considerations, the decision-making process that went into deciding on the dose to test, which can be a real challenge when you're limited to testing one dose for a large-scale trial with long-term follow-up. So you've seen this, but I do want to just emphasize again that these are the recommended dietary allowances, 600 and 800 above age 70. These are tolerable upper intake levels. Kind of keep this in mind as we go through some of the evidence. And again, the 25 hydroxy D level of 20 nanograms, 50 nanomoles, tolerable upper intake level, 50 nanograms, 125 nanomoles. I'm not going to go through that again. We've just discussed the average intakes. Some of them are background slides, which I can, if there's any duplication of the previous talk, I'll just go through them very quickly. So in terms of the evidence for non-skeletal outcomes, as I mentioned, the IOM committee spent a lot of time and went through hundreds and hundreds, a total of 1,000 papers, and most of them were non-skeletal outcomes. So we did look at autoimmune diseases, we did look at autism, we did look at cancer, cardiovascular disease, type 2 diabetes, a large number of outcomes. Also, the ARC, the Agency for Healthcare Research and Quality, had commissioned a systematic review, particularly focusing on non-skeletal outcomes, which was published. It was conducted by the Tufts Evidence-Based Practice Center. It was published in 2009. We looked at that. We also went far beyond it to look at additional papers that weren't included and some of the newer ones, 2009, 2010. But the conclusion of the ARC report was that the evidence for an association between vitamin D and cancer and cardiovascular disease was inconsistent. They also stated very clearly the evidence was inconsistent for diabetes, autoimmune disorders, really just about everything that you can imagine, including infections. That most studies, if you really look at the evidence in aggregate, show no significant association. Even the observational studies really have, there are a lot of null studies that don't receive a lot of attention. And most importantly, and I really found this to be overwhelming, that there had been no randomized clinical trials at all that had cancer or cardiovascular disease as a primary pre-specified outcome, where the clinical trial had actually been designed to look at whether vitamin D, higher dose vitamin D, could prevent cancer or cardiovascular disease. The papers that had been published in a randomized trial looking at vitamin D intake and cancer or cardiovascular disease were mostly osteoporosis or fracture prevention trials, where they had also reported on the relationship between the intervention and cancer, cardiovascular disease. And when it's a secondary outcome of that nature, you really have to be cautious and wonder how many outcomes were looked at. You know, is this a case where 20, 25, 30 different outcomes were examined, and what's being published is, you know, where there's an association seen? Was the study large enough, powered to look at those outcomes? Did they have good confirmation of cancer, cardiovascular disease outcomes? So these are important questions to consider. So just to give you the bottom line, we'll go through this in a little more detail. After looking very carefully at this evidence for cancer, CVD, and other non-skeletal outcomes, the IOM committee concluded, this is in the paper that you have from JCEM, did conclude that the evidence for an association is inconsistent. Most importantly, the evidence for an association is inconclusive as to a cause and effect relationship, that there just weren't the randomized trials, and the associations seen in observational studies, you know, could be correlations related to confounding or other issues going on, but there was really very little to suggest going above the recommended dietary allowances in terms of trying to prevent cancer or cardiovascular disease or these other non-skeletal outcomes. And that, therefore, the evidence for an association with these non-skeletal outcomes is not yet sufficient to inform dietary recommendations for the public, and that there was definitely a plea for more research, more randomized trial research. Probably there will be another IOM committee convened within 5 to 6 years to look at the results of trials that are now getting started, that are in progress. So I think you may not have to wait that long to actually have evidence where cancer, CVD, autoimmune diseases are being looked at as primary outcomes where these trials are really designed to look at these outcomes. We don't have to go through that. This just shows that for 6 months of the year, if you're above the 37th parallel, you're not even going to get enough sun exposure to have adequate endogenous synthesis of vitamin D. And one more reason why solar exposure is really not a feasible approach to getting adequate vitamin D. We've talked about all of the risk factors. You have to keep these in mind as you review the literature. Were they adjusted for? If these are risk factors, some of these, obesity, lack of physical activity, various medical conditions, race, ethnicity, if these are also risk factors for cardiovascular mortality, cancer mortality, outcomes like that, you need to look at whether results were adjusted, whether they were stratified, and be sure that there aren't confounders in the analysis. I do really want to emphasize these interrelationships because I think they play a very prominent role in the almost ubiquitous associations between low vitamin D and nearly every outcome that's been looked at. Even though the literature isn't consistent and you can always find several studies that don't show the relationships between low vitamin D and